клиническим случаям. Позвольте мне представиться, меня зовут Кислицына Наталья Михайловна, я работаю в МНТК микрохирургии глаза в Москве. И второй модератор у нас Аванесова Татьяна Андреевна, которая представляет международный проект Retina Bridges. И сегодня мы будем вести данную секцию. Надо отметить, что травма органа зрения – это не простая патология, а отличительной особенностью ее является такой полиморфизм клинических проявлений и то, что часто у нас профессионалы, которые работают в этой области, должны работать от полюса до полюса, как любят говорить офтальмотравматологи, то есть они должны обладать целым спектром специальных знаний и специальных умений. На сегодняшний день в России у нас несколько школ, которые занимаются травмой органа зрения. Это школа военно-медицинской академии, которую возглавлял Волков Вениамин Васильевич. В Москве травмой занимается Институт Гельмгольца, и развивался этот отдел под руководством Розы Александровны Гундеровой. В МНТК мы в основном занимаемся реконструкцией последствий травмы органа зрения и их последствий. И в этом году в рамках секции травмы органа зрения мы объединили vitreoretinальную конференцию и международный проект Retina Bridges, который ведет Аванесова Татьяна Андреевна. И таким образом мы протянули такие информационные мостики между Ростовом-на-Дону, США, Пакистаном, Египтом и Болгарией. И, конечно, поддержка 100 Конгресс, она обеспечит нам перевод как с английского на русский, так с русского на английский. И я надеюсь, что это позволит без труда наслаждаться и докладами, и дискуссией. Как вы понимаете, травмой занимаются особые люди. Как говорил Кун, чтобы заниматься травмой органа зрения, надо обладать креативностью, смелостью, умом, решительностью и настойчивостью. И только такие люди могут победить в такой борьбе за зрение, которой обладают участники нашей сегодняшней секции. И разрешите мне представить, кто у нас участвует. Куликов Алексей Николаевич, главный офтальмолог Министерства обороны Российской Федерации, Бойко Эрнест Витальевич, который возглавляет наш Санкт-Петербургский филиал. Это люди, которые являются одними из лучших выпускников школы Вениамина Васильевича Волкова. Также Юдина Нина Николаевна, которая заведует отделением vitreoretinальной хирургии нашего калужского филиала. Кожухов Арсений Александрович, который является одним из организаторов такой волшебной клиники «Спектр». Злобин Игорь Владимирович, который работает у нас в иркутском филиале. Казаков Илья Сергеевич, врач офтальмологической клиники имени Рашевского, Самара. И Яблоков Максим Михайлович, который работает в отделении Тамбовского филиала МНТК микрохирургии глаза. А наших иностранных коллег представит Татьяна Андреевна.
It's a great pleasure to welcome you, dear colleagues, to our session. Let me introduce you. Ahmed Magdibede, Professor of Ophthalmology, Alexandria Faculty of Medicine, Egypt. Thank you, dear Professor, for agreeing to take part in our session.
Thank you, Tatiana.
Lukan Mishev, Focus Eye Center, Mishevi, Sofia, Bulgaria. Thank you for being with us today.
Thank you.
And Hussein Kahan, Professor of Ophthalmology, Lahore General Hospital, Pakistan. We are happy to see you with us tomorrow. So let's start.
И начинает нашу секцию разбора клинических случаев Алексей Николаевич Куликов с докладом «Актуальные подходы к лечению травмы глаза».
Добрый день, глубоко уважаемые коллеги. Позвольте представить наш клинический случай. Традиционно в пятницу во второй половине дня поступает военнослужащий из одного из наших региональных госпиталей. Анамнез классический, строительные работы, перфоратор по кафелю. Осколок отскочил и ударил по левому глазу. Выполнена первичная хирургическая обработка на первом этапе в виде наложения швов на роговично-склеральную рану, и на третьи сутки после этого он поступает к нам. Острота зрения, движения руки у лица. Мы видим ушитую корнеосклеральную рану, травматическую катаракту. Глубже визуализация недоступна. Уточняем ситуацию при помощи босканирования и компьютерной томографии. Выявляем осколок высокой плотности по компьютерному томографу. А на боскане, кроме осколка, видим также катаракту и гемофталь. И берем в операционную. Здесь мы приняли решение начать с катарактальной хирургии. Мы понимаем, что по залеганию осколка, по локализации входного отверстия, по травматической колобоме радужки у нас капсула хрусталика повреждена, и хотя мы не относимся к тем докторам, которые стремятся во что бы то ни стало во время такой хирургии имплантировать искусственный хрусталик, тем не менее молодой человек, 20 лет, хочется, если не во время этой операции, то во время следующих все-таки имплантировать линзу таким образом, чтобы дать ему максимальную функциональную реабилитацию. Здесь вот этот этап как раз катарактальный в этом видеофильме довольно подробно освещен. Видно, что в принципе делается все довольно деликатно, и до конца удаления хрусталиковых масс было ощущение, что все получилось неплохо, что капсулорексис правильной формы, что он не соединился с зоной повреждения капсулы хрусталика. Но, тем не менее, когда мы заканчиваем этот этап, мы видим, что, тем не менее, стрелочка все-таки ушла на заднюю капсулу. Вот. И дальше мы тогда герметизируем входные доступы катарактальные, вводим вискоэластик в переднюю камеру и переходим к геометректомии, но начинаем ее с передних отделов стекловидной камеры глаза для того, чтобы исключить ущемление и выход волокон стекловидного тела через этот дефект в переднюю камеру. Дальше мы визуализируем инородное тело, видим, что оно довольно подвижно, и поэтому начинаем подбираться не напрямую к нему, а с разных сторон. Но во время такого, казалось бы, деликатного подхода инородное тело прыгает и повисает на волокнах стекловидного тела в аспирационном канале витреотома. Но мы решили эту неожиданную ситуацию обернуть в свою пользу, использовали это как элемент фиксации народного тела, подняли его в передние отрезки стекловидной камеры глаза, очистили витреотомом от волокон стекловидного тела и начали пытаться вывести его через имеющийся дефект задней капсулы, к сожалению, не запланированный, в передний отрезок, в переднюю камеру, для того, чтобы удалить его так называемым комбинированным путем, комбинированным доступом, предложенным на нашей кафедре в 2000 году. Во время всей этой операции мы неоднократно вспоминали работы профессора Верста, профессора Махачевой, Натальи Михайловны Кислицыной о значимости и важности топографической анатомии, вот, о том, как сложно устроена и задняя гиалоидная мембрана, и передняя гиалоидная мембрана. И вот здесь использовали вискоэластик для того, чтобы последние волокна стекловидного тела отодвинуть от инородного тела и не допустить увеличения вот этого вот повреждения задней капсулы, поскольку все-таки надеялись, рассматривали вопрос во время этой хирургии и об одномоментной имплантации. Вот здесь мы снова возвращаемся к передним отделам стекловидного тела. Когда мы вернулись на задний отрезок, мы поняли, что ситуация несколько сложнее, чем она казалась нам сначала. Что стекловидное тело пропитано не только кровью, вот, что оно очень вязкое, очень плотно спаяно с сетчаткой, в нижних отделах имеет такой мутноватый, желтоватый оттенок. Мы начали выявлять единичные запустевшие сосуды и вот такие на периферии эпителиальные интраретинальные кровоизлияния. Поняли, что имеем дело, к сожалению, с начинающимся эндофтальмитом. Вот, и на каком-то этапе прекратили попытки отделения и удаления задней гиалоидной мембраны. И с учетом этого выполнили барьерную лазерную коагуляцию вокруг зоны рикошета, где сетчатка была повреждена. Вопрос о линзе отпал сам собой. Интравитреально ввели гемазу, перибульбарно ввели кинолог, и на этом операция была завершена. Операция была в прошлую пятницу. По состоянию на вторник острота зрения с апатической коррекцией 0,3, глазное дно выглядит уже более благостно, запустевших сосудов уже нет, и видим зона рикошета, обработанная лазером. Ну, когда мы готовились к докладу, мы поняли, что, наверное, было слишком самонадеянно с нашей стороны называть его актуальными подходами к лечению травмы, потому что все актуальные подходы этот случай не иллюстрирует, но тем не менее он иллюстрирует то, что комбинированный путь удаления осколков сейчас является наиболее современным и наиболее щадящим и безопасным вариантом, что использование стандартизированных инструментов через стандартные доступы, которые мы используем для плановой катарактальной витреоретинальной хирургии, это предпочтительно, за исключением некоторых случаев больших размеров внутриглазных инородных тел, что настороженность в плане эндофтальмита должна сохраняться, что не обязательно самоцелью вот такой операции по травме это имплантация искусственного хрусталика в ходе таких операций. И что, конечно, нельзя забывать о фармакологической поддержке. Это ферменты, глюкокортикоиды, антибиотики, антиоксиданты, которые нужно и можно вводить и интравитреально, и перибульбарно, и внутривенно. Ну и вот то, о чем уже сказал, важность топографической анатомии. Ну, вопросы для обсуждения этого нестандартного, как и любая травма клинического случая, это вот техника удаления травматической катаракты при повреждении капсулы хрусталика, решение о применении тех или иных тампонирующих агентов для тампонады стекловидной камеры глаза, каким образом обрабатывать оптимально зону рикошета и каким образом применять или нет, какой длины волны лазер-коагуляцию при обработке таких повреждений. Спасибо за внимание.
Алексей Николаевич, большое спасибо за предоставленный интересный клинический случай. И здесь мы видим сочетанное повреждение заднего и переднего отрезков и достаточно сильное повреждение сетчатки в ходе вколоченного такого инородного тела. Обычно в таких случаях используют какую-то эндовитреальную тампонаду. И еще, конечно, вот воспалительный такой момент тоже. Считается, что если есть повреждение сетчатки, то лучше тампонировать каким-то силиконом в таких случаях. Скажите, пожалуйста, вот ваш выбор в этом случае уйти на физиологическом растворе обусловлен?
Спасибо большое, Наталья Михайловна. Да, это, наверное, один из самых диспутабельных вопросов. Мы позволили себе остановиться на такой тактике, учитывая специфику работы с льготным контингентом, с военнослужащими. То есть, когда такой пациент поступает к нам, кроме того, что мы должны провести лечебные мероприятия, мы также должны провести определение тяжести травмы, представление на военно-врачебную комиссию. И такой пациент у нас обречен на нахождение наблюдения в стационарных условиях на довольно длительный срок. Вот. Мы воздержались от использование тампонирующих агентов, потому что мы так много сил приложили для того, чтобы не расширился этот дефект задней капсулы. Мы прекрасно понимаем, что какой бы тампонирующий агент мы не выбрали, мы потеряем его. И поэтому, учитывая то, что пациент в стационарных условиях под ежедневным многократным наблюдением, мы позволили себе обойтись без тампонирующего агента, понимая, что мы в любой момент можем взять его повторно в операционную.
Можно я тоже спрошу?
Да.
Скажите, пожалуйста, Алексей Николаевич, вводились ли антибиотики интравитреально?
Когда мы интраоперационно установили диагноз начинающийся эндофтальмит, мы ввели в подачу ванкомицин в соответствующих дозировках. Потом, когда мы завершали операцию, мы выбирали между тем, чтобы ввести интравитреально ванкомицин в стандартной дозировке или использовать гемаз. Ну, мы знаем, что гемаза – это единственный отечественный препарат, разрешенный для интравитреального введения после плодотворного сотрудничества МНТК, Военно-медицинской академии и других российских учреждений. И мы знаем, что он не только обладает фибринолитической активностью, но еще и стимулирует отслойку задней гиалоидной мембраны. И поскольку гиалоида осталось много приретинального, и поскольку мы понимаем, что именно он может дать пролиферацию и осложнения в отдаленном периоде, то мы ограничились тем ванкомицином, который шел в ирригационном растворе по ходу операции, а в конце операции ввели гемаз. А кинолол, который тоже вот по данным нашей кафедры хорошо работает при перебульбарном введении, мы ввели, соответственно, перебульбар.
В ходе данной секции мы будем планировать небольшую дискуссию. Я бы хотела спросить Нину Николаевну, вот в данном случае вы бы использовали какую-то тампонаду или придерживались бы такой же тактики?
Я бы, наверное, согласилась с вами. Мы, скорее всего, завершили бы силиконовой тампонадой, учитывая, что все-таки элементы инфицирования какие-то есть. И для того, чтобы не повторять интраоперационный заход снова или новый этап операции, я думаю, мы бы ушли на силиконовой тампонаде. И при завершении успокоения в послеоперационном периоде явления воспаления, месяцев через 1,5, скорее всего, мы бы его удалили, силикон.
Спасибо большое. И следующий докладчик.
Thank you very much. And our next speaker. Our next speaker.
So can you see and hear me right now?
No, we can see.
You can see the presentation?
No. Yellow button.
So you can see it right now?
No.
Still no?
Oh, yes, it's okay.
Yes, now we can see.
Can see it right now? Still can see it, okay?
Yes, we can see.
So in the beginning, I'd like to thank Dr. Tatiana and the organizing committee for inviting me to participate in this meeting. My first video presentation is about a case of traumatic macular hole, which failed after the initial surgery. So this is about the 22-year-old male who received a trauma in his right eye by a tennis ball. This was since 1 month. His visual acuity on time of presentation was 0.1. I decided to go and remove the internal limiting membrane and inject gas in order to help closure of this macular hole. This is at the beginning of the first surgery. I'm removing the ILM until the edge of the macular hole. Peeling the internal limiting membrane 360 degrees. Trying to leave a flap at the end of the surgery to cover the macular hole. I extended the peel till the vascular arcades. Everything, in fact, went fine, no problems during the surgery. Then we proceeded to fluid air exchange. And then we made sure that the flap is covering the macular hole at the end of the surgery. This is 2 weeks after the surgery. The gas has been absorbed and the hole remained open. So the question is what to do now. I decided to readmit the patient for surgery, and I decided to make a free ILM flap, what we call an ILM graft. So I extended the peel of the internal limiting membrane, leaving a small part connected to the attached ILM, injected viscoelastic material, and I mobilized this ILM graft using the Teno diamond scraper to cover the macular hole. I injected again viscoelastic material to help preventing mobilization of the ILM flap, which actually occurs in a lot of cases. And an important step in this operation is to stop the infusion at the time of fashioning this ILM graft over the macular. And then again, done fluid air exchange, injected gas, and ended up the surgery. Now, 10 days after the surgery, the gas bubble is small and you can see it upstairs, and the hole has been closed. If you look to the lower OCT photograph, you can see the edge here of the free ILM flap covering the macular hole, and this is my first case. The second case is about a traumatic sub-ILM hemorrhage. This is about a story of an Egyptian pharmacist who was spending her honeymoon in Malaysia when she decided to jump from a height of 50 meters, what's called the bungee jump. You can see the patient while jumping. Her legs are tied with an elastic rope, which stretches until probably it's about 1 meter from water, and then it recoils again. And finally, they give her a stick to get her out of the jump. When she came out, this was the appearance of the patient. The patient experienced a dramatic drop of vision, and this was the appearance when she first presented to me. After 10 days, the condition was still the same. This appearance looks like as if it is a subhyaloid hemorrhage in the beginning, and we decided to remove this hemorrhage. At the beginning of the surgery, we induced posterior hyaloid detachment. You can notice the edge of the hyaloid making this wave. And when the hyaloid has been removed, no blood came out. You can see the blood moving under another layer, which was the internal limiting membrane. The blood was not in the subhyaloid space, it was in the sub-ILM space. We tried to create the opening with the aspiration port of the cutter. We know that it's safe in this region because the blood is separating it from the retina. And then we used the forceps to peel the ILM. And once we completed the peel, the blood is getting dispersed in the vitreous cavity. And it was easy to clean the vitreous cavity, and the surgery has been finished. This is the appearance at the time of presentation, and this is 5 days after the surgery. This is 5 days after surgery, and this is 2.5 months later. the vision of the patient has been regained, restored again, and the OCT demonstrated this appearance. You can notice corresponding to this yellow edge here, there is what looks like a proliferative change of the retinal pigment epithelium producing this appearance in the OCT. Thank you very much.
Thank you so much, Professor Magdabeta, for sharing such interesting, great cases. I have one question. First case, do you think the reopening this hole was due to shifting the ILM flap or not? Because you decided to repeat the method.
You know, Tatiana, there are cases in which the surgery with removal of the ILM do not work. Still, we have cases, probably in my hands, about 15% of the cases do not close after the initial surgery. So we have to search for something else. Probably it was due to shifting of the flap, as you mentioned. However, in some cases, we don't know why these cases failed. In this case, this was actually my first time to try the ILM graft to close the second hole, and it did work. However, I should admit that some of these cases, when we go and do simply fluid air exchange without doing any flaps, holes close also.
Thank you. And if you don't have success in your second operation, what would you do? Maybe silicone tamponade?
Usually in these cases, I don't prefer using silicone oil tamponade. I don't feel that it gives better chances for closure of these holes. However, after 2 surgeries, I would hesitate a lot before deciding to go for a third surgery.
Thank you. Is there any situation in your next case when you decide to wait when you have internal limiting membrane hemorrhage?
I think we should not wait a lot because the sub-ILM hemorrhage can organize. And in these conditions, removal will be much more difficult.
Thank you. Dr. Mishev, what is your approach if you don't have success with first surgery, macular hole surgery?
Thank you. That is really difficult question to answer because I also have some percentage of non-closure after first surgery, and I give that to probably something in the macula, because since I started to drain into the macula until I see that the hole is closed, my percent of primary closure climbed. Otherwise, if it's a traumatic closure with really large diameter, actually I would go for retinal autograft because I think that it works if it's done properly, and it can provide even functional gains, whereas the inverted ILM flap is only a scaffold for closing the macula.
Retina graft with silicone tamponade?
Sure, I'm using heavy silicone, and my idea is to keep the graft attached firmly because in my cases we showed some early OCT signs of retinal reintegration.
How can you explain the recovery of function?
Mueller cells, they are the architects of the retina, and there are studies published which claim that Mueller cells can change to photoreceptors, and it is proven in monkey studies, so primates.
Thank you. Dr. Hussein, what is your approach if you have reopening macular hole?
Thank you, Tatiana. If we have a secondary macular hole, mean you did the first surgery and hole didn't close, and you did ILM peel, etc. So my approach for secondary macular hole is that I use amniotic membrane graft for these secondary macular holes. But the thing here is that Professor Ahmed showed the case first one where he redid the surgery. If you see the idea of second surgery was not to plug it. Idea was second surgery to give the scaffold. My understanding is that these large traumatic holes, they need time for centripetal movement of the edges. And it takes long for the centripetal movements. If they take longer, the holes remain closed. But when you give the scaffold over the hole, then they close easily. So this scaffold that you gave in the second surgery of the ILM over the macular hole helped to the centripetal movement and it closed the hole. Because there is nothing else you did. You just put the ILM over hole and it closed. The same principle I am using for amniotic membrane graft for secondary macular hole. I don't plug these holes with amniotic membrane graft. I just use the amniotic membrane graft as a scaffold, as a covering the hole, not filling or dipping inside. That's all.
Thank you so much.
Следующий доклад представит
Next report will be done by Boyko Ernest, St. Petersburg. His research group includes Hizhniak and Scheffer, vitreoretinal technique in the surgery in anterior and posterior segment surgery. Thank you very much, Natalia. Good afternoon, dear colleagues. So the essence of our report is that the eye, of course, has two segments, the posterior segment and the anterior segment. And firstly, we could do brilliant surgeries in the anterior segment, and now we could operate and could do posterior segment surgery quite well. And according to our experience, I'd like to demonstrate you the case. This is a girl, 14 years old, with poor vision, light projection. There was a car accident 2 years ago, and there was an injury with a glass fragment. And we could see iridocorneal scarring with anterior synechia. And we could see leucoma and absent pupil here, and we could see local retinal detachment. And I'd like to demonstrate our technique, which is performed with a vitreoretinal instrument. These are scissors which can perform different functions. And you could see that we could wash out viscoelastic, which was used in the anterior segment. Usually we use viscoelastic for the posterior segment of the eye, and Alexei demonstrated us brilliant surgery. If there is the risk of vitreous drop and the risk for macula and for the optic disc, then we could apply viscoelastic there too. And we make the pupil and we dissect synechia to maintain endothelium and to create the anterior chamber. Then we do iris fixation and anterior capsule fixation, and we do capsular rhexis, and we could see the anterior segment surgery, aspiration and irrigation, vitreoretinal technique. So we examine the optic fundus, and we could see the local retinal detachment not progressing. we perform laser coagulation in this case and go up to the serratus line. And the next step is just on the one hand, we'd like to do something about retinal detachment. And after implantation, we did cryopexia, massive cryopexia in the site of retinal detachment. And we know that cryopexia could provide inflammation, and so just it can lead to local attachment. As a result, the visual acuity is of 0.4, and there are some elements of astigmatism, but we could see that we made the right decision, and we don't see the local retinal detachment. There is a chorioretinal adhesion developed, and so we can think that refraction surgery could help us in the future, and we could see that conjunctiva looks quite well, and we control the central chest parts, and they look well too. So as for the posterior segment, vitreoretinal technique could be also applied in the anterior segment. Thank you very much for such a brilliant technique, Ernest, for demonstration of the new vitreal instruments applied in your surgery. Could you tell us, please, that this was a trauma which happened 2 years ago, but if it is a fresh trauma, do you use implantation or not? Yes, we do implantations, and we implant intraocular lens. Yes, if there is a capsule, so we implant intracapsularly. If the capsule is injured, then we implant on the anterior capsule. If there is no capsula at all, then in this case we could do implantation at a later stage. And this is good that when it is a severe trauma, then we could do silicone tamponade, and then we could divide the anterior and the posterior segments of the eye. So when we do reconstruction, we usually think that tamponade will be needed. And I'd like to ask one more question. I'd like to ask Igor. Do you use vitreoretinal instruments when you perform a reconstruction of the anterior segment of the eye? Yes, of course, we do apply, and I also would like to make some comments. I'd like your technique, I'd like the way how you form the pupil. We also use this technique, and these instruments are quite comfortable to manipulate in the anterior segment. And the next report will be done from Kaluga and made by Yudina, Nina, and she will demonstrate different ways of foreign body removal. Dear colleagues, let me introduce our work on the ways to foreign body removal. And we know that the open injury is up to 60%, and about 1/3 is or belongs to the foreign bodies to the posterior segment. So our clinic is one of the clinics which can provide emergent medical care for our population. So we have a lot of patients who really require urgent surgery. And we prepared some clinical cases for you according to different ways to remove the intraocular foreign bodies. I don't want to focus our attention on the history, and I only can say that this is an open eye injury, type C and D, and I'd like to demonstrate you some aspects of our work. And there are different signs of foreign bodies, and they can be classified by localization and some other parameters, and the way of removal depends on localization, on location of the foreign body, and it should be effective and preferably from the first attempt, and it should be less traumatic. As less traumatic as possible. So this is the conjunctival injury. So at the beginning of the quarantine, and we proved the diagnosis with ultrasound. We didn't do an X-ray, and our original hospital was closed, and we couldn't do an X-ray in this situation. So when we examined the sclera, we didn't find any wounds on the sclera, and we didn't find any foreign body or the signs of the injury. While doing vitrectomy, you could see that there is the retinal injury and choroid injury, and with the vitrectomy we didn't find the foreign body. We could suggest that this is just little injury, like a penetrating injury, penetrating wound, and we could suggest that the foreign body could be located in the posterior parts of the eye, and we used the phanoscopy, and with that method we could locate the foreign body, which was located intraspirally, and with the magnet we could remove. It was a metal plain metal little foreign body, which could be removed with the magnet. And here so this is a pneumatic wound, and we could see the spheric foreign body in the orbit, and we could see just in this situation we could see the inlet opening, and the exit opening was located near the optic disc. And in this situation we always should find the foreign body. It was a magnetic foreign body, and with a magnet we could remove the foreign body in this case. And I'd like to notice that such penetrating injuries are difficult because it's difficult to suture the entrance opening by layer, and that is why these injuries could lead to sympathetic ophthalmia. And the next case is a big foreign body. This is a piece of platinum, and this is a central injury, so we had to remove the lens because the foreign body was of quite big size. And of course, to remove such a foreign body is quite traumatic, and we did it through the anterior camera. If we do it transclearly, then we could do a bigger trauma to the eyeball. In that case, evacuation of this foreign body into the anterior segment was less dramatic in such case. Could we start the video? So we can use perfluora to prevent hemorrhagic intraoperative complications. And when we have retinal detachment, we also can use these tamponates with perfluora, and later on we should apply or just administer antibiotic therapy. It's not always easy to grasp the foreign body. It can be of different configuration and of different size.
Использование среды воздух тоже нам помогает.
So the use of the air also helps us to do adequate laser coagulation of the retina, and later we could use silicone oil. So, and use the properties of silicone oil. So silicone as well as perfluora are the best buffer media which can prevent the retina. And perfluora and silicone oil both prevent the changes of the intraocular pressure with a large scale opening to remove the foreign body.
Запустите оба видео. В данной ситуации нам для...
In this situation, for localization of the foreign body, we used coherence tomography in a deeper location of the foreign body. It is difficult to remove it, and it is removal can be even more dramatic than leaving the foreign body in the eye. So, and there are some difficult and dangerous locations of the foreign body if it is located near the optic disc, and the main arteries, main vessels can be located nearby, and coherence tomography could allow us to remove the foreign body in a safer way. In one more case, you would see the linear wound of the conjunctiva, and with paracentesis along the wound canal, we could remove the foreign body. We implant the lens into the capsula, and the retina in that case was intact. it was not affected. And for the successful surgical treatment, the location of the foreign body is very important. According to the characteristics of the foreign bodies, there are different methods of determining the locations. These are our old methods and the new methods which doctors could apply successfully. And the main principle is that our modern diagnostic equipment allows us to perform the just surgical treatment at a time. Dear Nina, thank you very much for demonstrating what is necessary, what kind of X-ray methods should be applied in case of trauma and in case of confusion and open trauma and orbit injury which can be diagnosed. And thank you very much for demonstrating different ways to prevent the macula when removing the foreign bodies, because one of the most important complications is just the loss of foreign body during its removal. My question is, there is such a method as buckling of the zone through which the foreign body is evacuated. Do you apply this method in your practice or not? No, we don't use it. So in this case, the entrance opening was near the macular zone, then buckling could be even more traumatic in that situation. Thank you very much for such a brilliant presentation. I'd like to ask Maxim, could you tell us please, do you use in your practice any methods to prevent the macula when when removing the foreign body? You can mainly use perfluora to prevent bleeding in the postoperative period and during the operation.
Share your experience with us. Lucan, can you share your presentation?
Yeah, sure. Here it is. Do you see my presentation?
Not yet. Yes.
Can I start?
Yes, please.
So, dear colleagues, I will share two cases in which there is a trauma. First one is ammunition explosion, and we have non-magnetic plastic pellets from a shell. So it's a two-stage surgery. In the first surgery, I removed the pellets, and then was the question, how can I calculate the length where there are no functional case? So we decided that we will use refractive Virgin's formula, and we will put 3-piece MA60 IOL with Yamane technique. And now you see how we advance the needles. And here I want to point something really important. The PMMA haptics are not really well suitable for Yamane technique. Now you will see how there is a fairly dangerous bend of the haptic because it's not so flexible. I would advise for Yamane technique PVDF haptics as Zeiss Wuchia, which are far more flexible. Otherwise this haptic can bend or broke. Here obviously I got lucky, but this is an issue which we can face with Yamane technique. I'm using 27 gauge needle. It is always good to see if your haptic fits the needle woman, because it will be not really nice situation if you realize that the haptic cannot enter the lumen of the needle when you are in the eye. So now the lens is already placed. Now with cautery we make small buttons, and the haptics are tucked into the conjunctiva. And we decided to use a mortual pinhole IOL, which is sulcus add-on IOL, hydrophobic one, really easy to be maneuvered and implanted, and it sits perfectly fine in the sulcus. So we implanted this pinhole lens over the MA60 in order to correct as much as possible the irregularities of this post-traumatic cornea. So here I'm carefully placing the haptics in the sulcus and above the Yamane fixated IOL. So actually we need to be really careful in this in this construction. So this is actually the end of the case, and that's it, how it looks. So next case is traumatic cataract with Carle-Vale IOL and iris circlage. So this is a blunt trauma. You see that there is a rupture, obviously. I tried to save the capsule as much as I can, but the capsule was also with teared zonular support in 6 o'clock. There were, as expected, fallen pieces from the cataract, and I was lucky to have a relatively soft nucleus, so it was easy to be eaten with the vitreous cutter. I'm using 23 gauge cutter, and now I think in every traumatic case we need to try to induce a PVD in order to clean as much as we can of the vitreous which is there, to avoid late complications related to retinal detachment and so on. We always need to check the periphery because there are trapped pieces from the fallen cortex or nucleus. Here I'm using horizontal scleral pockets on 2.5 millimeters from the limbus, but the hole is on 2 millimeters. I'm using curved instrument 23 gauge, which is for anterior segment surgery, because it's more convenient. Here I'm able to intercept the leading anchor of the Carle-Vale IOL in order to engage it directly to the scleral pocket. So once you intercept the anchor, you can slowly introduce the rest of the IOL. Then you can put the IOL in the anterior chamber, and since this is a vitrectomized eye, I'm using the infusion on. What is surprising is that the lens is actually really flexible. Here I have damaged the anchor during the loading, but still I have functional anchor. With handshake technique, we can easily pass the anchor to the other instrument. And now I'm using a technique described by Ike Ahmed for iris circlage. The needle is Alcon PC9. This is a ProLens suture with this 14 millimeter curved needle, which I find really convenient for such a maneuver. And step by step we need to engage the iris. I'm using 27 gauge cannula to guide the needle through a paracentesis, and this maneuver is repeated in all 3 quadrants. Then I'm using a Sipser sliding knot to tighten the circlage, and I avoid intracameral tightening. And this is the end of the case. So thank you.
Thank you very much, Lucan. Your videos are beautiful. I have a question. In first case, did you perform complete vitrectomy?
Yes, as I said, this is a 2-stage procedure. In the first procedure, complete vitrectomy with PVD induction because there were numerous foreign bodies in the posterior pole also.
what are the indications of using this type of lens, extra focus?
For me, this is the main indication could be corneal irregularities or probably post-RK patients. Otherwise, it extends the depth of focus, but I don't imagine it using it as a presbyopia correcting device.
Thank you. Thank you so much. Do you have such experience with such lens, Professor Beda?
No, at all. This is my first time to see it.
And Hussein?
Sorry, Tatiana, can you repeat the question?
Do you have such experience with extra focus lens?
No, I don't use it. I don't have any experience with it.
Thank you. And не могу не спросить Арсения Александровича про во втором случае.
I'd like to ask Arseniy, what type of lens would you use in the second case? Do you have any preferences about intraocular lens? With a wide pupil with traumatic mydriasis, what tactics would you apply? A lot depends on the patient's age. I would prefer three-step lens with Yamana technique. So Dr. Kalivari demonstrated a perfect lens, and Dr. Abramov demonstrated to us this lens for the first time in Russia. I think that this is a brilliant example because there are no threads and there is nothing to be dissolved, and for young patients this is quite a good option. Thank you very much. In Russia, this type of lens is not registered yet, so we cannot apply this lens in our surgical practice, unfortunately. And Arseniy will present his clinical case, the retinal detachment on the only eye with post-traumatic aphakia and aniridia. Thank you. Dear colleagues, I'm happy to welcome you. Thank you very much for the opportunity to participate in this conference. And my clinical case will be devoted to the eye injury. The one eye is subatrophic. Many years ago, the patient had a trauma to the second eye. 10 years ago, as a result, aphakia developed and almost complete aniridia. And he was admitted to the hospital with a fresh hemophthalmos and with retinal detachment very close to macula. We could see two tears or even 3 tears during the operation. And the patient could distinguish between, we could distinguish between the anterior and the posterior segment, and we could treat the retinal detachment. So the plan was retrocoagulation with sutures, and our technique that we applied was so-called the Star of David Star. So, and you could see the triangles, at least 2 triangles allow us not to just make incision on the conjunctiva, and it allows us to put silicone in the posterior segment. And first of all, we tried to separate the capsule sac. The sac was significantly contracted, and then we work with the retinal detachment, and we did vitrectomy, and we injected the fluorine and then perfluora, and we did a laser coagulation around the tears. And after that, we started to work with intraocular lens. And this sac was contracted and too small for our lens, and the lens couldn't be located into this sac, and the lens was dropped on the bottom. And then we used the vitreal forceps and we tried to evacuate the lens. In that situation. And fortunately, we could do it successfully, and then the lens was implanted back, and in such a way it can be implanted successfully, and this fixation was not sufficient, and the air got into the anterior segment. That means that the silicone could go to the anterior segment as well, and we could do some sutures to limit the anterior and the posterior segments. And here you could see how I put the sutures on the sclera, and so this is a special technique when we put the sutures like a triangle. That's why our technique is called David's star, because it looks like a David's star. And once again we fill with air, and a little bubble is there, and the third triangle was made in front of the lens. So there were two rows of sutures behind the lens and one row of suture in front of the lens, so it was quite reliable. The air didn't go to the anterior segment, and everything which was left in the posterior segment could be evacuated. We used the air, and we did calculation. And after that, silicone tamponade under air. You could see that the anterior segment is not filled with viscoelastic. This patient had a full retina attachment in 2 days with quite severe astigmatism, and the visual acuity 0.3. So in his life after trauma, he had never had a vision better than 0.3. And then we decided to remove silicone at the second stage with 2 portal system for silicone removal, which now is available for our Russian doctors, and we can remove the just caps, and with 2 syringes we could remove the silicone, and it can be removed for 1-3 minutes. So it can be done very fast during 1 to 3 minutes. And then we do or we use just the air again, And there, we can see that there is no viscoelastic in the anterior chamber, anterior segment. So it didn't go to the anterior chamber. And then we finish our operation. So we finished under water. And as a result, we achieved the visual acuity of 0.30.4. So, and the patient had astigmatism, and the lens was implanted, and the patient was very happy about the result of the surgery. Arseny, thank you very much for such a wonderful technique, which can just demonstrate your experience. I think it's very nice. And of course, I have a question. Didn't you want to implant Irida lens diaphragm, all the complex, the iris, including the iris? Thank you very much. We discussed that with the patient, but I didn't want to do it at the first stage. So when we had retinal detachment, because it could complicate all my vitreoretinal manipulations, because the diaphragm, it could be difficult to implant the diaphragm. We discussed with the patient that we would do the implantation in a certain time, but as a result, the patient disappeared and he didn't come back. So probably the patient was satisfied with the result and he didn't want to improve anything else. Thank you very much. Did you remove viscoelastic between putting sutures? Maybe viscoelastic prevent air going to the anterior segment at the final stage. Yes, I use viscoelastic when I worked with lens, but during the vitreoretinal surgery, I didn't apply viscoelastic. For me, the marker was when I didn't see the air in the anterior segment, it meant that the viscoelastic didn't go to the anterior chamber. When you put the third row of sutures, did you remove the viscoelastic before each layer of sutures? Yes, we did. Dear colleagues, I'd like to ask you, there is a technique with a phakia and an iridia to do paracentesis to prevent ciliary body injury. I'd like to ask Alexei, how would you do a vitreal operation with paracentesis or with vitrectomy? So if I can understand your question correctly, then in Russia, this technique which was demonstrated was firstly applied in Russia at the department named after Boyko, and it was used initially used as a technique for the treatment of quite simple diabetes and for foreign bodies removal. And in such an interesting clinical case, I think this technique couldn't allow us all the possibilities. Ernest. Yes, I really think that this technique was complicated, but we talked then about the peripheral tears. And when we use peripheral tears, it's better to work with portals. If everything is located in the center, like just the foreign body, or when it is diabetes, when we need to dissect only the posterior membrane, then we could use only vitreal instruments. and we will be not limited in our work. And there is one more aspect, that an iridia is not an indication for this technique. So a narrow constricted pupil is an indication for such technique. Because in this case we don't have problems with mydriasis. So our next speaker is Igor Zlobin. Dear colleagues, thank you very much to the organizers. Thank you for the invitation. I will show you the video. I don't have the presentation. Could you start my video, please? So my case is penetrating injury with intraocular foreign body. We work with lumbar scarring. The anterior segment is intact. There is traumatic coloboma, but you cannot see it here. And our surgery starts with lens removal. This is a child, 12 years old. The lens is almost transparent. And with aspiration, it can be easily removed. Later on, to remove the foreign body, we decide to do it transcorneally, but we implant intraocular lens, and it can be rotated to make it easy to remove. And with vitreal cavity revision, we could see a glass segment and the complete retinal detachment. We do vitrectomy first and try work carefully with the macular zone. Then we work very carefully and try to remove the foreign body, and we do posterior capsular rhexis to remove the foreign body through the hole in the posterior capsule. And after forming an opening in the posterior capsule, we mobilize the foreign body. We use two just instruments to fixate the foreign body, and we try to move it to the anterior segment. And we need to move a bit intraocular lens, and we do paracentesis. And then we put eye all back. And we are preparing for the removal of the foreign body. We incise the cornea. We do a corneal incision. And here you could see the curved glass. And from the history, we understood that it was a bulb, a broken bulb, and a glass piece got into the eye. Then we put sutures on the conjunctiva. And the retinal detachment started with PVR. This trauma happened 3 years ago, and only 1 month ago the child lost vision. And we didn't understand why there were such retinal tears. Maybe it was as a result of proliferative vitreoretinopathy, or probably due to another reason. This is like a puzzle for us. Of course, we should work with all periphery to evacuate the laser foreign or to evacuate the glass foreign body, and we should work on the air and do the silicone tamponade. We use Denseron because all tears are mainly in the interior segment. We fill the cavity with silicone and do the sutures. The silicone is not evacuated here, and we will leave it as long as possible. And there are a couple of pictures with demonstrating our just the glass foreign body, and it's of quite a big size. That's all. Igor, of course, you demonstrated us your wonderful technique. Could you tell us, please, how all silicone is in the eye? If there are no proliferative membranes and proliferative symptoms, about 1 month silicone is in the eye. So the patient visited us very recently. There were no signs of emulgation. According to our experience, we understand that it will be difficult to make a decision about silicone removal. A lot will depend on the intraocular pressure, on emulgation. We will see what we will do in the future. Do you think about the substitution to another type of silicone? We will see what will be the situation with the retina in the zone of tears. What methods do you apply to remove the foreign body? So I like the method that we demonstrated to you, not only when we remove the large foreign bodies, but also when we remove the small foreign bodies. I think that this technique is quite optimal to remove the foreign body, not to just lose it, and to avoid the risk of retinal injury. So in many cases we use the technique which I demonstrated to you.
Can I have one comment, please?
Foreign body, yes, please, Lucan.
Wonderful case and wonderful technique for removing such huge foreign body. Just a comment about the Denseron 68. It will definitely emulsify for 3 to 4 months, and it became sticky and not easy to remove. So in that time period, if the retina requires, I would suggest changing this silicone with 5000 or 5700 light silicone. This is only my recommendation.
Thank you, Lucan. We just talked about it, that surgeon is thinking about future actions.
Mm-hmm.
Thank you. What is your choice, preferable choice, how to remove intraocular foreign body?
It depends.
Sclera or cornea, if this patient, a child with transparent lens?
In fact, I would also remove the lens. And I think that the cornea approach, especially for the large foreign bodies, is the more better one, because you don't induce any trauma in the ciliary body or in the pars plana. You don't know where are you exactly with such huge size foreign body. So I definitely would remove it as the surgeon did, through the cornea.
Thank you. Hussein.
Yes, very interesting case, Tatiana. He did a wonderful job. My only concern was that he should remove the cataract, obviously, or it's a clear lens, but he shouldn't implant the IOL in start. If he hadn't implanted the IOL in the start, he could do easily posterior capsulorhexis, and then he can easily remove that large foreign body without traumatizing the endothelium, iris, or other tissue. So you see, just putting the IOL is no hurry. You can put the IOL at any stage of the surgery, because you know that, because before the surgery we knew that it's a large foreign body, and he had the plan to remove it from the limbal wound, from corneal wound. Okay, then there was no logic of putting the IOL in the start, so he made his job a bit difficult just putting the IOL. Otherwise his approach is fine. And second thing is, if this foreign body is not that much large, I wouldn't remove the crystalline lens in kids especially. In people who are less than 40 years of age, I wouldn't remove the clear lens. I would prefer the pars plana site to remove the foreign bodies. It depends. In my presentation, you will see I have used the both approaches. I will show you in next few minutes. But it depends the size, condition, age. These all three things matter: age, size, and the condition of the eye. That decides that which site is good for to salvage that eye's vein. That's all.
Thank you, Professor Beda.
Yes, I totally agree with Hussein that there was no hurry in putting the intraocular lens at this point, as this makes removal of the foreign body with such a large size more difficult. So I would remove the lens, make posterior capsulotomy, remove it through the limbal approach, and then implant the IOL later on. One thing also that I think I will not end up the surgery with putting densure on. Regular silicone can work in these cases, so I don't use densure in such a case.
Thank you. Илья Сергеевич, какой бы вы метод выбрали, учитывая возраст пациента и прозрачный хрусталь?
What method would you use, taking into account the age and the transparent lens? Yes, of course, I would remove it through the anterior chamber with lens implantation. Thank you very much. And the next speaker is
Can you see my presentation, please?
Yes.
No, we can't see.
Yes, I can see it.
Is it there?
Yes, everything is okay.
Okay.
You can start.
So my presentation is about the intraocular foreign body. Размет имеет значение. So I will just show the surgical videos of few cases. In these cases, I just try to convey a message about the size of foreign body and how the size does matter. So this is my first case. You can see a small foreign body inside the vitreous cavity. Not a difficult case, it's very simple case, basic case, you just remove the cutter. But I am not doing the complete vitrectomy at this stage. I don't want this foreign body to fall on the retina. So I did the little bit core vitrectomy, and with the end grasping forceps, I am holding this foreign body. It's very easy, no? But here you see what happened. But here you see, I lost the foreign body. Where is the foreign body? So this is sometimes it's very difficult to find the lost foreign body. So I have to indent it, and here you see, I found it over the pars plana area. It is lying over here. So you need to indent the anterior retina and vitreous base to find the lost foreign body if it's lost during the pars plana removal. So then I dislodge it. Vitreous was there. I used the vitreous as a scaffold, and then the foreign body didn't touch the retina. It was lying in the vitreous, so I hold it once again. And then you see this time I am successful. So here is a small foreign body. So just a message in this case that you can lose the small foreign bodies even if the wound is not adequate. So you have to be very vigilant. If you lose it, just indent the anterior retina, and most probably you will find these cases. So now I am going for the second case. Here you can see the old trauma old hemorrhage, not fresh much. So the thing here is the foreign body is lying over here, inside the hemorrhage. It's very difficult sometimes to remove it. Just I am using the special forceps, that's a magnet claw forceps. This forceps has a magnet, and oops, I lost it, and it drops once again. But I am using the magnet in this class, so then I just touch with the magnet and you can lift it. And then I put it over the scaffold of the hemorrhage. And then again, you can just lift it from that area and safely you can remove it. So dropping of the foreign body and then lifting it from there, I use this 3-claw magnet forceps and it helped me a lot. So here you can see the foreign body has been removed from pars plana. So you see it's a magnet forceps, so it's just have a attachment with it. So now I am showing you the third case. I just put a few cases from my list of intraocular foreign body cases. So these are all the different, they are presenting the different scenarios. So here you can see the foreign body is deeply embedded in the retina. You can see the foreign body is over here, and I am doing the vitrectomy. And during vitrectomy, you see there's a little bit hemorrhage from the vitreous, and there's around the foreign body. So I am removing that hemorrhage and just trying to find the foreign body. So I used the endocortary and I did the laser around the foreign body area. Then I'm using the end grasping forceps, and you see the foreign body is deeply embedded. It's very deep inside the sclera choroid. So just lifted it from the retina, and you see, and it's removed from the pars plana area. So these are the foreign bodies, and I showed you the different scenarios in all three cases. So now I am showing you the fourth case. Here the patient has a trauma intraocular foreign body. These are the preoperative image. These are the CT scans showing, and this is the scar. We did cataract extraction. It's a soft cataract. So here you can see the lot of hemorrhage. So this patient was referred to us, so I did the 23 gauge pars plana vitrectomy, removing the fresh hemorrhage. So the foreign body here, you can see the foreign body is in the inferior but anterior retina. But it's a very large foreign body. I am using the large forceps. So it is in the anterior part of the retina, but it's inferior. So you can see the size of foreign body, it's huge one. So I am just bringing it out from the anterior chamber from the limbal wound. Because I did cataract extraction, the lens was deficient posterior capsule, and the surgery was ended with the completion of the vitrectomy. IOL was inserted, and these are the post-operative images. So now I'm sharing my last case. This is the fifth one. This is also traumatic. You can see the scan, and here is the CT scan. There's a lot of vitreous hemorrhage, not very fresh intraocular body. This is also the referred case. The primary surgeon did the corneal tear repair, and I am doing the vitrectomy. Not much dense hemorrhage, but it is there. So you have to remove it. It's not problem. So, but the foreign body is embedded again in deep retina. So I am doing the basic principle, doing the laser around it. The foreign body, you see, I have to remove the debris, even the retinal tissue, even the choroid tissue from the foreign body area. Then I have to dislodge it. You see, I am bringing it out from the choroid. So I have to dislodge it, and then I am holding with the forceps in the minimum diameter area. So you see here, it's a large size, but I am removing it from the pars plana. So I didn't have a deficient capsule. So this is the large size foreign body, about 9 millimeter of the length. So you can use the different approaches from the limbal wound or from the pars plana, depending on the situation, depending on the IOL situation, deficient capsule or not. but the preference should be to minimum harm the patient's eye and not to damage the tissue structure, because these are already traumatic eye. Thank you so much for your kind invitation for this speech, and I am done with my presentation. Spasiba.
Thank you so much for your beautiful videos, for your Russian words. Thank you so much. Dr. Hakan, I have several questions.
Yes.
First, do you have some special technique how to prevent macular area when you can have choice to lose your foreign body? Do you use maybe viscoelastic or?
Yes. The preference is most of the times you are experienced, if you are experienced surgeon, you can hold the foreign body, you usually don't lose it. Your wound is adequate to the foreign body size, but sometimes you may miscalculate the foreign body size and your wound. Then you can lose that foreign body in pars plana area and anterior retinal area. But rarely you lose it to fall on the macula. But you can have a macular area, you can use the PFCL or viscoelastic to prevent if it drops back down to the macula. It may prevent to harm the macular area, traumatize the macular area. But usually it doesn't drop over there. It usually entangled in the sclerostomy area or anterior pars plana area or in the anterior retinal area. It doesn't dip down to the macular area. Second thing, I usually don't complete the posterior hyaloid detachment before removal of the foreign body. So I used the posterior hyaloid as a surface that if it happens, then it may prevent to traumatize the retina. Second thing is, after completion removal of the foreign body, I usually do the complete removal of the posterior hyaloid, complete the vitrectomy, and 360-degree encircling laser must for all the intraocular foreign body patients, even if there is no retinal break. Yes.
Thank you. Have you observed any anterior vitreoretinal proliferative aspects?
Yes. In these cases where the foreign body is deeply embedded in the retina and choroid, yes, in these you usually get the retinal break, and the choroid is also traumatized, and you get later on lot of inflammation. That lot of inflammation converts into the PVR, and that PVR may convert into the retinal detachment. That's why I usually do the encircling laser, 360-degree encircling laser. I essentially do the vitreous-based shave and laser around the retinal break, and I use the endotamponade of 5000 centistroke silicone oil in these cases. So that may prevent for 3 or 4 months. If there is even PVR, then you can handle it easily. Second thing is, Professor Kuhn described it that you can do the retinectomy and choroidectomy in this area. Then there will be little exposure of the choroid that may prevent the PVR proliferation in the future. Yes.
Thank you so much. Илья Сергеевич, ваш доклад следующий.
Thank you very much. Ilya, your speech will be the next. Thank you very much to all organizers for the opportunity to participate in the conference. Could you please switch on my video? I'd like to present you a case of surgical treatment in paintball trauma. So the patient was admitted to the hospital after playing paintball, and paintball went under the mask. The patient lost vision, and on admission, on the optic fundus, we could see the retinal detachment, the subretinal bleeding, and we started vitrectomy from removal of the central part of the vitreous, and we insert per fluor to prevent moving the blood towards the macula. Then we examine the peripheral part of the vitreous. After that, we start to remove necrotic choroid. And during the removal, we face with choroid bleeding. We try to stop bleeding with increasing the pressure. And with time, we can deal with this problem and the bleeding discontinues. And we assess the membrane rigidity. Also, we continue to remove the necrotizing aspects after the repeated bleeding from the choroid. We could understand that we have to stop removal of the tissues, and when working in the periphery, we could see that the tissues can move easily, and now the retina could be separated from the choroid, and we fill the vitreous cavity with perfluora, and we could remove the hemorrhages, and substitute perfluora to the air. Under air, we try to remove the hemorrhagic parts, and at the end of the operation, we tamponate the vitreal cavity with silicone oil, and we start to think what to do with the patient later on. We follow up the patient, monitor intraocular pressure, and in 8 months, we made a decision about removal of the silicone and cataract removal at one step. So we remove the cataract without any any problems, and we implant the lens, intraocular lens. We examine the vitreal cavity, remove the silicone under the air. The retina is attached, and the choroid is also attached, and there is no tendency for the detachment. And before discharge from the hospital, the visual acuity of the right eye was 0.06 due to chorioretinitis and the atrophy of the operated eye. Thank you very much to Ilya. So we congratulate you and the patient with such a result. And one question I'd like to ask you, did you use laser coagulation? No, we didn't do laser coagulation. So the adhesion developed itself, yes. Due to hemorrhage, there was adhesion developed without coagulation. So Dmitry also told us about such cases. Thank you very much. We should go on, and our final report will be made by Maxim Yablokov, foreign body removal. Dear Tatiana and Natalia, I'd like to present you our case, foreign body removal. So a patient was admitted to our clinic, born in 1988, with the complaints with vision loss. In the history, he worked in the just in the car service, in the car center, and he felt like something just got into his eye, and he went to the ophthalmologist, and with the diagnosis of hemophthalm, conservative treatment was administered, but later he was referred to our clinic. On examination, we could see the bleeding in the inferior parts, and we could find out retinal detachment and the foreign body near the serratus line. And the diagnosis, intraocular wound, retinal detachment. Could we start the video, please? We performed the three-portal vitrectomy with the elevation of the posterior hyaloid membrane. In the next step, we inserted perfluora with the fixation of the foreign body, and then we separated conjunctiva from the sclera in the zone of foreign body. Then with the forceps, we could trap the foreign body and we pull it taking into account that situation, we made a decision. It was difficult to remove the foreign body with such a forceps. We decided to change it and to take another one with sharper branches. Then we put sutures on the sclera and conjunctiva with double sutures. And then we performed the standard therapy for the retinal detachment. We drained subretinal fluid, and we switched from BSS to the sterile air. Then we substitute BSS solution with the air. We do end-laser coagulation in the just location of the foreign body and retinal tear. Then we removed pre-retinal fluid over the optic disc. And the final stage was to examine the zone of laser coagulation and do silicone tamponade. In the intra-operative and post-operative period, there were no complications, and we were planning to remove the silicone in 1 month. In 1 month, the patient visited us again. We didn't reveal any complications, so the retina was attached, and we did silicone removal with 27 gauge. And we do the examination of the vitreal cavity and didn't see any complications, so the retina was attached. We substitute BSS solution to the sterile air. And once again examine the vitreous cavity and the zone of the foreign body location. We could see retinal attachment, and there is a good adhesion developed, and the final stage is to remove the pods and put sutures on sclerotomy. The results in 1 month. So left eye vision acuity is of 0.3, intraocular pressure is of 18 millimeters mercury, and then the patient will be followed up. Thank you very much for your attention. Maxime, thank you very much for sharing with us your experience. And I think that in the future you're planning further emulsification of the cataract. The patient visited us and the cataract hadn't developed yet. The patient is quite young, but the cataract wasn't developed. And one question from our hall: which antibiotic do you usually administer in the treatment of post-traumatic endophthalmitis? Thank you for your question. It is considered that the antibiotic number 1 is vancomycin, and there is the dose for intravitreal infusion 0.1 milligram per 1 milliliter. And the concentration that we used in the irrigation solution is given in the guidelines, in payment, and in our guidelines, in our monographies. Nina, could you tell us, please, do you use antibiotics or what antibiotic for endophthalmitis? I also agree that we use vancomycin. Ernest? Antibiotic number 1 is vancomycin, and we also use ceftazidime, cephalosporins. And we are going to finish our session.
Your knowledge with us. We're happy because your participation made this session very fruitful and educative. I hope you enjoy it. Thank you very much.
So much.
Thank you.
Thank you very much.
Thank you.
Уважаемые коллеги, большое спасибо за ваши
Dear colleagues, thank you very much for your brilliant presentations. Trauma is the most interesting and the most difficult in ophthalmology and ophthalmic surgery, because surgery is always interesting. And thank you very much for the organizers and for technical support. Without their help, such a brilliant project would be impossible to conduct. Dear colleagues, we should say a lot of thanks to Kislitsina Natalia and Avanesova Tatiana, who could moderate our session today very successfully.
Thank you, Lucan, and thank you, Hussein.
Уважаемые участники, в следующей части видеосессии будет проводиться интерактивная